Hello, and welcome to the Psychiatric Mental Health Nurse Practitioner Review. We are going to talk about sleep. So, how to assess sleep in a patient is to really look at their historical sleep pattern. Some people can function on much less sleep than others, so we want to make sure that there is some change from baseline. Also, sleep can be measured with a polysomnograph. So there is rapid eye movement or REM sleep, which alternates with 4 distinct non-rapid eye movement stages called non-REM sleep. So stage 1 is a non-REM sleep. It is the lightest sleep stage. It can last up to 15 minutes. During this time, we can see things like hypnotic jerks or drowsiness. Muscle tone begins to relax. It's a transitional stage from the wakefulness to sleep and 5% of total normal sleep cycle. Stage 2 is also a non-REM sleep. It uses or has specific electroencephalography waveforms. It is more difficult to wake the person up when they are in stage 2. Body temperature and heart rate begins to decrease, and this takes up about 50% of the total sleep cycle. Then we have stage 3, which is also a non-REM sleep. It is a slow wave sleep period. We have delta waves in this period. It's a deep and restorative sleep. It is the most difficult to awake. This is when parasomnias occur, like sleepwalking, night terrors, and sleep talking. And this takes up a total of 5 to 15% of the total sleep. And stage 4 is the REM sleep. This is the dreaming stage where eyes move from side to side, active brain waves, but they can be easily awoken, but will feel the most groggy when they are awoken in the REM stage. So general considerations, sleep stages are organized and sequential during sleep periods. So stages 3 and 4 tend to occur in the first 1/3 to 1/2 of the sleep period. REM occurs cyclically through the night, alternating with non-REM on an average of every 80 to 100 minutes, and REM increases in duration towards morning. Sleep patterns vary with age, so children and adolescents have large amounts of slow wave sleep, and sleep continuity and depth decreases with age, so consider age when assessing for sleep problems. And as we can see, you don't need to memorize this, but awake, stage 1, stage 3, and REM sleep all have different wave forms, which is just interesting to know on an EEG. So alterations in sleep. We can have problems with sleep due to medications, substances or alcohol, caffeine, and other stimulants. Medications that can affect your sleep. So there is a whole list of them here. Again, you don't need to memorize all of this, but it is just kind of nice to know the things that can disrupt sleep. For example, beta blockers can cause insomnia, nighttime awaking, and nightmares. Clonidine can cause daytime drowsiness and disrupt REM sleep. Corticosteroids can give people the jitters and insomnia. Diuretics can have increased nighttime urination, painful calf cramps during sleep, etc., etc. So insomnia is the significant inability to initiate or maintain sleep or early morning awakening with the inability to return to sleep, and occurs at least 3 nights a week for a month or more. It can be situational or acute, which lasts for days or weeks. If it's a month, it can be episodic. And if it's more than 3 months, it can be persistent insomnia disorder. Having insomnia increases mortality, poor career performance, overeating, and increased hospitalization. The incidence and cause of insomnia. So usually there is a dysfunction in the sleep-wake circuits of the brain. There's neurochemical imbalances that can impinge on these circuits. They can be stress-related. 33% of Americans have difficulty sleeping, and 10% meet the criteria for insomnia disorder, and it's highly comorbid with other psychiatric conditions. Risk factors, so it happens more often in women who are older or people who have a history of insomnia or are under a lot of stress. Can also happen due to like shift work, traveling different time zones, or sleep apnea. In order to prevent and screen, we always want to check, children and adolescents. We want to teach people to limit shift work if they can, avoid medications that can disrupt sleep patterns, have good sleep hygiene, avoid stimulants later in the day, and early recognition and intervention. So when assessing, we want to look at the insomnia history. Again, that's going to give us a better idea of what the diagnosis is. Is this an acute problem or is this been going on a long time? We want to look at social history, drug use, medications, the hours of sleep, sleeping pattern, different types of insomnia. So is there, somebody who has difficulty falling asleep, that initial, or is it like a waking up in the middle of the night, that middle, or is it the early morning awaking? We can teach them to use sleep aids, have better bed positioning or pillows, have better environment, the temperature, sound, and sleep. And we can use Epworth Sleepiness Scale, and it is a questionnaire to assess for excessive daytime sleepiness. A score will range from 0 to 24, and anything greater than 10 needs further investigation. So we talked about insomnia. So now there's another disorder called hypersomnolence disorder. So this is a self-reported excessive sleepiness despite adequate sleep. They have difficulty being fully awake. They feel groggy after abrupt awakening. Occurs at least 3 times a week for several months with significant distress or impairment, not better explained by another sleep disorder, viral infection, or physiological effect of a substance. It may occur within 18 months of experiencing a head trauma and can be comorbid with things like mood disorders. The next diagnosis we're going to talk about is obstructive sleep apnea. So this is the hallmark of the disorder is snoring and repeated apnea during sleep, which leads to daytime sleepiness and not feeling refreshed after waking. They can have a headache upon waking. Consequences include panic attack, or it co-occurs with panic attacks, ADHD, depression, hypertension, motor vehicle, and workplace incidents. Affects 2% of children, but 15 to 20% of adults. It can be due to an abnormally small nasopharynx, tonsilary tissue in children, or obesity. And weight risk factors include excessive weight, obesity, diabetes, smoking, high blood pressure, or narrowed airways. So polysomnography can make a definitive diagnosis. It records the brain waves, oxygenation, heart rate, and involuntary leg movements while sleeping. So we want to do an assessment. We always want to do an assessment, right? Where we're looking at physical and mental status. We want to look at labs like CBC, chemistry profiles, thyroid function tests, ferritin levels, B12, drug toxicity, and then rule out any conditions that might contribute to the symptoms they're experiencing. Some differential diagnoses. So more than 50% of insomnia cases are related to a primary psychiatric disorder. So all of these psychiatric disorders, and there's some medical disorders in there as well. There is that's the primary disorder, not the insomnia. The insomnia in half of the cases is caused by something else. So it's important that we identify that. So obstructive sleep apnea, we can promote weight loss, avoid supine sleeping, positive airway pressure, continuous or bilevel for sleep apnea, so the mask that they wear at night to help them breathe correctly. Narcolepsy, so 2 or more episodes of sleep latency less than 8 minutes, or 2 or more episodes of sleep with rapid eye movement periods. This is when they just fall asleep during the day. Another sleep disorder is restless leg syndrome. So when they are falling asleep, their lower limbs start to move, creating an irresistible urge to move their legs, which disrupts the initiation of sleep. It's unpleasant. They have discomfort. We want to assess for iron deficiency, akathisia, neuropathy, neurovascular disease, or osteoarthritis. And how we can treat this is with dopaminergic agents, anti-epileptic drugs, or alpha blockers. So pharmacological management of insomnia. So we can look at melatonin if they are having sleep onset issues. Benzodiazepines or hypnotics, these should not be used for obstructive sleep apnea, right? Because it's going to suppress the respiratory tract, and they can also be highly addictive, and they also can cause fall risks in the elderly. And have residual drowsiness. So sometimes they're not the best, but sometimes they are what have to be used. And so those are just some examples of benzodiazepines there. Non-benzodiazepines, so there are quite a few options. Sonata, Ambien, Lunesta, Rosarum, Bellasora. We can use these as well. Some other options. Sometimes we can use antidepressants for their sedative properties. For example, mirtazapine is used a lot off-label to help people sleep. Also can help with appetite. And then trazodone technically is an antidepressant, but that is used quite often for sleep as well. For wake-promoting agents, we can use modafinil or armodafinil to help with daytime sleepiness associated with obstructive sleep apnea, or for people with hypersomnia. So sleep hygiene practice, we want to teach patients to establish a bedtime, have a regular sleep-wake cycle, avoid computer and electronics an hour before bed, never lie in bed for more than 15 minutes if not able to sleep, reduce stress, avoid late daytime exercise or stimulant use, such as caffeine. Use the bedroom for sleep or intimacy only. Consider moving phone or other devices away from the bed area. We can have them do psychotherapy or cognitive therapy for insomnia. So here are just some ideas for interventions that can be used for insomnia. So sleep diaries, psychoeducation, sleep restrictions, control stimuli, sleep hygiene, cognitive behavioral therapy, allocate worry time. So people who ruminate at night, you can tell them to schedule a time to worry during the day. So say like 15 minutes, we'll say 5 to 5:15 every day to worry about those things. But then when you go to bed, you say, I'm not going to worry about them till tomorrow at my worry time. So sometimes that can work for people. Non-pharmacological management, so we can teach them relaxation and other therapies. We talked a lot about this in the psychotherapy discussion, and then somatic and other therapies. So insomnia in children usually is related to stress. Usually children with insomnia have been poor sleepers since birth. We typically don't use pharmacological treatment in kids. Nightmares in kids can be linked to genetic factors. And then insomnia in older adults. So usually it is the result of chronobiological rhythm changes. Sleep latency, decreased REM sleep, and increased sleep fragments are common. Insomnia can be related to psychiatric disorders in older adults, and older adults often manifest confusion and restlessness as aspects of insomnia. So that is the end. Thank you so much. I'll see you next time. Bye.